Okay, let's unpack this. We've got these revision notes on alopecia areata, and the plan for this deep dive is simple. Turn these notes into really high-yield, easy-to-remember points just for you.
Exactly. We're trying to cut through all the detail, get to the core stuff you absolutely need for revision, make it stick.
Right. So jumping straight in, alopecia areata, what is it fundamentally based on these notes? Let's start with the absolute basics, the definition.
Okay, so at its heart, it's an autoimmune condition. That's the key takeaway. Your immune system gets confused and starts attacking your own hair follicles.
And what does that actually look like clinically?
You see these very characteristic, well-defined bald patches. They're often round or oval, usually scalp, but the notes mention the beard area too. Smooth skin in the patches.
Ah, and there's that distinctive sign, isn't there? The one that's great for visual recall.
Yes, the exclamation mark, hairs. You see these short, broken hairs around the edge of the patch, narrower towards the bottom near the scalp. It's a real classic sign mentioned in the notes.
Got it. So, cause autoimmune. But what about triggers or risk factors? Do the notes give us clues?
Well, beyond just saying autoimmune, the notes highlight links with other autoimmune conditions. So things like thyroid disease, vitiligo, even diabetes. If you have one, your risk might be higher.
And genetics.
Definitely a factor. The notes point to a family history in about 20% of cases.
Right.
So there's, genetic predisposition involved. It's often a mixed genes plus some kind of immune trigger.
Okay. And pathophysiology just hammers home that same point, right? Immune system attacking follicles.
Pretty much, yeah. It
Really?
disrupts the hair growth cycle right at the follicle level because of that immune attack.
Let's talk numbers then. Epidemiology. What are the key stats you need to remember from these notes?
Okay, so prevalence in the UK is around 0.1 to 0.2%, maybe 15 people per 10,000. And interestingly, it hits all ages and genders pretty much equally.
No bias there, and typical age of onset.
It can happen anytime, but the notes say it's common in childhood or adolescence. The peak seems to be between 15 and 29 years old.
Anything else linked to it?
Yeah, nail changes.
Yeah.
About 10–15% of people get things like pitting or ridges on their nails. Worth looking out for.
Okay, this feels really important for managing expectations. The notes talk about spontaneous remission.
Absolutely crucial point. The notes state that up to 80%, which is, a lot, can see their hair grow back on its own without any treatment.
But there's always a but, isn't there?
Yes, recurrence is common, so it can come back. And unfortunately, for about 14–75%, you can progress to more extensive loss. Alopecia totalis, which is the whole scalp, or even universalis, the entire body. So the course is variable.
And are there clues, like prognostic factors, that suggest a tougher course? What do the notes mention?
Yeah, they list a few things suggesting a poorer outlook for regrowth. Those nail issues we mentioned, starting really young, having widespread loss already if it affects the scalp margins. Also having a kikatapy like eczema or asthma history and other autoimmune diseases. Those are markers.
Okay, so visually we're looking for those patches, smooth skin, maybe the exclamation mark hairs. Diagnosis, then, is it complicated test?
No, the notes suggest it's usually straightforward, primarily a clinical diagnosis, based on seeing those characteristic features.
But other things cause hair loss. What are the main differentials mentioned in the notes? What else could it be?
Good point. Key things to rule out are androgenetic alopecia, that's typical male-female pattern, baldness, looks different. Then tinea capitis, a fungal infection. You look for scaling, maybe different broken hairs. And trichotillomania, that's hair pulling. So you'd see odd hair links. Maybe get that history.
Right, pattern and other signs are key. So if it is alopecia areata, what about management? What options are in the notes?
Several things. First line is often corticosteroids, either topical creams or intralesional, meaning injections right into the patches. Immunotherapy is also mentioned.
Any others?
Yes, things like minoxidil solution, phototherapy like PUVA, topical stuff like dithranol, or contact immunotherapy trying to modulate the immune response locally. And of course, wigs are an option too.
And what about regrowth chances with treatment?
Notes suggest maybe 50% see regrowth within a year, perhaps 80–90% eventually see some recovery. But it also notes referral to dermatology if more than 50% of the scalp is affected.
And beyond just the hair treatments.
Two really key things emphasized. Check for those other autoimmune diseases we talked about. And, crucially, psychological support. This can be really tough emotionally, so counseling and support are vital.
Makes total sense. Are there times when the notes suggest not treating?
Yeah, if regrowth is already happening spontaneously, or if the person doesn't want treatment, or if the hair loss is quite limited, like less than 50%, it's a shared decision, really.
Okay, so prognosis is variable, can regrow,
Huh.
but complications are mainly the psychological side and the risk of it becoming more extensive, especially if those negative prognostic factors are present.
Exactly. And I think what really comes through from these notes is that dual need to manage the physical autoimmune process, but you absolutely cannot ignore the psychological impact. It's about the whole person, not just the scalp.
That's a really important point to finish on. So that wraps our deep dive into these alopecia areata notes. We've hit the autoimmune nature, the look, the stats, the unpredictable course, how it's diagnosed, what else it might be, and the management, including that vital psychological aspect.
Hopefully, distilling it like this makes those key facts a bit easier to lock in for your revision.
Absolutely. And if you found this breakdown useful, remember there's more help available. Check out pastmsra.com and also freemsra.com for more resources.